Hi everyone, my name is Sammy. I'm accompanied by Nicole and Kelsey, and today we'll be presenting on POCUS and Inflammatory Bowel Disease, otherwise known as IBD. We have some objectives for you. We'll be going and discussing through what is IBD, the types of IBD, why it's important to detect IBD, specifically on ultrasound, the gradings of IBD, normal anatomy seen in the colon and throughout with diagnosis of IBD, normal POCUS anatomy, POCUS IBD flares, and then how we integrate this actually into our practice. So just to kind of start our conversation today, we'll kind of discuss a little bit about what IBD is. And so specifically, IBD is a diagnosis or condition that can be kind of categorized further into either two things, either Crohn's disease, also known as CD, or ulcerative colitis, also known as UC. And this condition is characterized by chronic inflammation of the GI tract, and often prolonged inflammation will lead to damage that is seen in these patients. The most common presenting symptom is diarrhea, whether that looks like it's bloody or it's just voluminous diarrhea. Also, abdominal pain, rectal bleeding, weight loss, and fatigue are seen in these two diagnoses. The most common or gold standard for diagnosis is either an endoscopy, specifically for Crohn's because of the skip lesions and the kind of distinction of mouth to anus for Crohn's, or colonoscopy for either ulcerative colitis or Crohn's. You can also use other imaging modalities to help diagnosis, such as CT, MRI, and blood tests and stool samples are very helpful in the diagnosis. Specifically, we look for inflammatory markers in these two conditions, such as CRP and ESR. We also look on a CBC for things like anemia. The LFTs are often affected in both of these conditions. And then specifically with Crohn's, and also seen in UC as well, you can see malabsorption, which can lead to B12, iron, ferritin, or vitamin D deficiencies, but ferritin would be elevated. The stool samples is specific for inflammatory properties, but you also want to kind of go ahead and rule out other infectious causes or etiologies with the cultures. We won't get into the specifics of how IBD is treated, but I just wanted to mention that it is important because ultrasound specifically is used in IBD to monitor response to some of the treatments that we use. For example, when we're starting a biologic in a patient, you can actually monitor the progress or the response of the biologic agent through serial ultrasounds. Again, as mentioned, there really are two most common types of IBD, that being ulcerative colitis and Crohn's. There's also this third kind of indeterminate category that's not often used, but it is important, specifically with reference to ultrasound, to kind of know the difference between the two. Specifically in ulcerative colitis, this is usually a continuous pattern that's seen starting in the rectum and often affects the lower colon. And this only affects the inner lining or the mucosal layer, which is very important for distinguishing for ultrasound purposes. Crohn's is usually a skip or patchy type lesion, and it can be anywhere kind of mouth to anus. This is transmural inflammation. You'll see it in all three layers, which again is very important for ultrasound diagnosis. And then this is just a picture kind of highlighting or demonstrating the differences. So here you see on the Crohn's, you see the skip lesions that can be seen throughout. And again, the most commonly important or part that's affected is the ileum. And then in ulcerative colitis, you see this kind of contiguous or continuous pattern that often starts in the rectum and proceeds throughout the lower colon. The reason it's important to detect or monitor IBD is for several reasons. We can help decrease morbidity and mortality in our patients. We can decrease hospitalizations and healthcare costs and the time to treatment onset. And obviously using POCUS, it can be a little bit more cost efficient. And instead of getting serial CT or MRI scans, these are very expensive tests. We can decrease the radiation in our patient population by using ultrasound. Specifically in pregnant patients, this might be useful, whereas you really don't want to use a CT or MRI. POCUS is also more feasible in poor socioeconomic areas. Ultrasound's often more accessible than a big, bulky CT machine. And obviously, ultrasound is less invasive. It can be done at the bedside and is very well tolerated by our patients. Again, we won't specifically get into IBD grading, but there is one kind of system or classification that was kind of set up in 2021, known as the IBD DCA. And this is really a way that we can kind of identify ulcerative colitis and Crohn's in the same kind of classification system. The D stands for kind of the distribution of chronic or active histopathologic modifications. The C kind of stands for the chronicity of the things that are seen histologically, and then the A is activity parameters, specifically looking at neutrophils. This is kind of a chart that just kind of depicts that and how we're able to identify both. The reason this is important, the classification system, is because, again, we can kind of identify how our biologics or agent that we're using to treat is working for our patients. So specifically, you can use this classification, and this is what you would look for to see if your patient's in remission versus a response to the agent itself. I'll go ahead and pass on to my colleague for the rest of the talk.
So when starting with intestinal ultrasound, knowing the anatomy is extremely important. So first we'll start with histology. As you can see on the left-hand side, inside to outside layers of the small bowel are the mucosa, submucosa, the circular muscular layer, the longitudinal muscular layer, and then finally the serosa. And as you can see on the right side, this is an ultrasound depiction of a normal GI tract showing the classic 5 layers. You see the superficial mucosa going to the deep mucosa. The white is submucosa, following with muscularis, and then also serosa. The first layer, the superficial mucosa, which we'll talk about, is brightly hyperechoic on ultrasound. This is usually due to mucus or tiny air particles that can be seen throughout the small intestinal villi. It's not separatively identifiable. However, with feces, when it's blending, it can be seen as hyperechoic, as you can see in the image depicted to the right. And then the outer white serosa can only be identified when there is ascites. When there's no ascites, you will not see this. Next is the deep mucosa. This is a hypoechoic structure, variable thickness as well. You can see the histological picture on the right lower, and this shows the prominent lymphoid tissues that's in the deep mucosa, known as the Peyer's patches. And those will show as different hypoechoic structures throughout the deep mucosa when you're using intestinal ultrasound. The next slide shows submucosa. So this contains vessels, nerves, and fat, which is why it's mostly hyperechoic on ultrasound. And due to the abundant loose connective tissue as well. On the right side, you can see a Doppler depiction with showing vessels in the structure. And then on the left side, you can see as well this hyperechoic line. And then following, submucosa also loosely connects the mucosa with the muscularis. So anytime the intestines are contracting, you can see the submucosa following the mucosal folds, and then after drinking water, the mucosa and the submucosa are stretched and unfolded, which you can see on the right side. So the intestines in this layer take on different appearances based on whether there is water or any other substance present. The next layer is the muscularis. This is a hypoechoic layer due to muscular tissue. So you can see the outer black layer is very easy to identify on the intestinal ultrasound, which is seen on the right side. The muscularis layer consists of 2, an inner circular muscular layer and then an outer longitudinal muscular layer. And these coordinate with each other to produce peristaltic movements of the intestine. These 2 muscular layers are separated by a thin layer of connective tissue, which contains neural tissue of the outer back plexus. And you can see this on the right-hand side. This thin layer is hyperechoic on ultrasound. And usually you can see this pretty well in small bowel of lean patients. The muscularis layer in the large bowel is slightly different from that of the small bowel. The longitudinal muscular layer has longitudinal oriented bands known as tinea coli. And in the empty compressed colon and thin patients, these can be identified as thin hyperechoic lines, as you can see in the intestinal ultrasound on the left lower side. And then the right side is just an animated depiction of the tinea coli. The next layer is the serosa, or the visceral peritoneum. It's very thin outer hyperechoic layer. Usually this blends in with the fatty tissue of the mesentery and the omentum surrounding the bowel. If there is intraperitoneal fluid, you will see this hyperechoic serosa easily identifiable, as you can see on the right-hand side in the ileal loops. Normal ultrasound of the small bowel is usually seen with continuous and vivid peristalsis, even if the lumen of the small bowel is empty. You can also see small round echolucencies with hyperechoic borders throughout the small bowel, and this depicts normal vessels seen throughout. And then also there is a thin hyperechoic line within the muscularis that we previously talked about, representing the Auerbach plexus, which is in between the longitudinal and circular muscle layers. And then the lower right-hand side is just normal small bowel in the longitudinal plane. Moving on with a depiction of the jejunum, mostly located in the left upper quadrant, as you can see on the left-hand side, and contains slightly more folds than the ileum, which is located in the right lower quadrant, and it's seen on the right image ultrasound depiction. Normal ultrasound of the ileum, usually it's separated from other organs in the pelvis just due to its specific location. As you can see on the right-hand side, the cecum and the ileum there, usually located in the right lower quadrant, and you can sometimes see lymphoid hyperplasia of Peyer's patches in the terminal ileum based on pathology or prior infections. And then small bowel wall thickness is pretty important when completing intestinal ultrasound. Sometimes it is difficult to measure this because of the peristaltic movements of the small bowel. The measurements can be done when the small bowel is compressed. As you can see, lighter compression on the left lower side makes the bowel wall thickness vary considerably, whereas on the right lower side, you can see moderate compression of the small bowel, which gives you a more reproducible and accurate depiction of the small bowel wall thickness. And normal small bowel wall thickness is about 1.5 to 2.5 millimeters. In Crohn's disease, there is slightly difference in the small bowel wall thickness. Usually this is around 6.5 millimeters, so enlarged. And as I previously stated, you would compress the small bowel in order to identify the small bowel measurements for thickness. Normal ultrasound of the colon, this is a longitudinal view on the left-hand side and transverse view on the right-hand side. This is an empty sigmoid colon in a lean patient, so very easy to see. And then you can see those muscularis bands that we previously talked about in the tinea coli, as you can see with the hyperechoic line and the 3 arrowheads. So normally, normal colon can be filled with feces during the left. The middle image shows contraction of the colon, and the right side is showing you compression of the colon, and this is how you measure the wall thickness. During compression, it's usually about 3 to 4 millimeters. And then there is oftentimes acoustic shadowing of feces, which you can see throughout intestinal ultrasound.
Okay, now to get into bowel assessment with POCUS. So a few things we can look at, one being the bowel wall thickening. So this is the distance between the mucosal lumen interface, which is going to be that hyperechoic layer, and the serosal muscle layer. Another thing we can look at is bowel wall pattern. So it's normally multi-layered, as Nicole said, but in the case of intestinal disease, it can be disrupted, and then severe disease, you can even see disruption or loss. Next, bowel wall flow, defined by the presence of vascular signals detected by color on that Doppler flow. Some other things that we're familiar with seeing in IBD patients are ulcers, strictures, fistulas, and abscesses. So with ulcers, this is represented by depressions in the mucosal layer. Strictures, you can see wall thickening with a narrowed lumen with or without dilation. Fistulas, you'll see a hypoechoic tract, and again, with or without hyperechoic content within. And an abscess is seen with an anechoic lesion with an irregular wall. This is going to be your transverse colon, again, with some bowel wall thickening. C and D, so we're going to have a stenosis here in C, and then D is going to be some pre-stenotic dilations. E and F, we're going to be seeing that hypoechoic fistula formation there. in this group of images, we're going to be seeing in A, so that's going to be your sigmoid colon, but with normal bowel wall thickness and normal echo pattern. In B, we can see some dilation here. And let's see, this arrow here is pointing from where you turn from normal to the dilation. So that point, and you can see the stenosis here, and then it goes into the dilated bowel. This slide here, we can see a lot of inflammation, and we have the Doppler as well. So that can indicate blood within the bowel. Next, this group of imaging. So in this, we can see some lymph nodes outside of the bowel, and then within the bowel, we can see some blood flow and then dilation as well. And then this is a good image to represent thickening of the wall as well. So integration of POCUS into practice. So mucosal healing is now aggressively pursued as a therapeutic target in IBD, and it's associated with decreased rates of hospitalization, surgery, steroid use, and risk of malignancy. The normal gold standard for assessing disease with IBD patients is the ileocolonoscopy. However, ileocolonoscopy is invasive and associated with risks to patients. POCUS has been shown to have comparable accuracy in terms of establishing disease activity and extent of both UC and Crohn's compared to the ileocolonoscopy, as well as other imaging modalities such as CT or MRI. POCUS has a 91% sensitivity, 83% specificity in detecting endoscopically active IBD, and that correlates with a PPV of 89% and an NPV of 86%. POCUS for IBD surveillance is very big in Europe right now, and they're using it in their clinical office settings. So I think this is something that's going to be more widely used in America. Conclusions. So POCUS is a non-invasive alternative to ileocolonoscopy for monitoring disease activity in IBD, and it's underutilized in practice, at least in the United States. POCUS is accurate in defining disease activity and extent in IBD. POCUS allows you to identify bowel wall thickening, pattern, and flow for the diagnosis of an IBD flare. POCUS is a more readily available, cost-efficient, and quicker imaging modality in detecting IBD flares compared to CT, MRI, or ileocolonoscopy. POCUS has comparable sensitivity and specificity in detecting IBD flares compared to CT, MRI. And here are our references. Thanks so much.